Good afternoon, everyone. I'm Dr. Venkatesh Egbote. I welcome you all this afternoon on behalf of Indian Society of Blood and Marrow Transplantation for our patient support group webinar. I'm so proud and happy to inform you that thanks to the support, encouragement, and feedback from all of you from the patient support group across India, we are today in our 12th webinar and we are completing one full year of this activity. Uh, Thank you everyone for the support, and we wish to continue this good work in association with various support groups. Um, Next slide. So these are our platinum partners for today's webinar session. And today we are into the 12th webinar under the mentorship of Dr. Tapan Saikia, Dr. Naveen Khatri, and Dr. Revati Raj. Uh, Through these webinar sessions, we intend to empower, educate, and enable patients in their journey uh, during and after bone marrow transplantation. And towards that, today we are talking about a topic which is a problem for many of the patients through the transplant journey and thereafter. It is called GvHD, or graft versus host disease that affects the eye. As all of you are aware, it takes a lot of toll on the quality of life, and and we need more options and treatment avenues to tackle GvHD of the eye. I welcome our speaker for today, Dr. Shrikant, esteemed consultant, ophthalmologist, and expert in the field of IGVHD. He's joining us from Apollo Cancer Care Center, Chennai. He will share with us his experience, his expertise, his thoughts about how he approaches a patient and treats the patient of graft versus host disease affecting the eye. Over to you, Dr. Shrikant.
Yeah, thank you so much, Dr. Venkatesh, and thank you to Revati ma'am as well for giving me this opportunity. Um, so, uh, Basically, today we'll be discussing about ocular GvHD and the way how to diagnose it. What are the recent advances, and how do we manage children who are suffering from ocular GvHD, and how we can prevent them in our day-to-day practice. Next slide, please. So, graft versus host disease is again, as we all know, it's an immune mediated disease, and it happens because of an interaction between the lymphoid tissue of the donor along with the recipient's immunocompromised state, which happens after transplantation. So this is across multi systems. This happens, and it can be classified as acute and chronic. Initially it was based on the time frame. Now it has a much more specific classification. Next slide, please. So how does this graft versus host disease occur? So this happens when the immunologically competent T cells, or either their precursors, they are transplanted into the recipient body, and they are immunologically compromised. So what happens is the all these graft T cells, they perceive these recipients' tissues as foreign, and they react against it. So all this leads to activation of the CD4 and CD8 T cells, which leads to inflammation and killing of the T cells. Overall incidence of GvHD, ocular GvHD in general, is 1 to 2% in general population. Next slide, please. So this is again a slide which shows the pathophysiology of the same condition, whereas in you basically see all these things which I mentioned happening, and it mainly affects the lacrimal gland, and it also causes inflammation of the ocular surface. So at the eye level, these are the two main structures which happens. So the lacrimal gland in very severe cases is fibrosed because of the activated fibroblasts and the dendritic cells. And the inflammation of the ocular surface happens because of the activated T cells. Next slide, please. So Bone marrow transplantation, umbilical blood cord, as well as the peripheral blood stem cell transplantation. All these put together is the allogenic hematopoietic cell transplantation. So any of these can lead to GvHD, and especially the ocular GvHD. Next slide, please. So then we come specifically to the ocular manifestations. So as I mentioned previously, both GvHD can be either acute or chronic in onset. Acute onset GvHD usually doesn't involve the eyes, and it usually is noticed in the chronic stages, wherein more so when the other systems are involved, like the skin, lungs, liver, GIT, and mouth and genitalia. So, it's as I mentioned, it is caused by tissue inflammation and fibrosis. Next slide, please. So this is the how the GvHD affects various systems, and I want to specifically mention the ocular features here, wherein any child who has undergone BMT starts getting newer onset of gritty or painful eyes, with on examination is found to have cicatricial conjunctivitis, keratoconjunctivitis sicca, or punctate keratopathy. What all these means, we'll come to it later in the further slides. Next slide, please. So, in general, eye involvement after, as I mentioned, in acute GvHD is very less. It's about 7.2%, whereas in chronic GvHD after HCT, it's about 30 to 60%, which is very high. It can even be early feature of a chronic GvHD, one of the early signs of chronic GvHD. And in the mean latency of ocular GvHD after HCT is about 1.5 years. Next slide, please. So, which children or which kids are more at risk of developing ocular GvHD? This is a very important slide. We need to focus here, because here we'll know who all we need to focus or concentrate on, so that we can reduce the incidence of such conditions in children post BMT. So, uh, if there is a previous acute onset of GvHD, then in further in those kids, they are more at risk. And if peripheral blood stem cells are used, again, they are more at risk. Especially, there are various studies for all this, and transplantation from a female donor to a male recipient has increased risk of ocular GvHD. Absence of anti-thymocyte globulin prophylaxis given, then also the child is at risk.
I think there is a connection problem with the presentation. Uh, Neera,
Yes, sir.
is there a connection problem?
Yeah, we have lost sir, Dr. Srikanth.
Okay. So, so far, Dr. Shrikant has already spoken about
Sir
the.
has rejoined again, I think.
Yeah, all right.
Sir, are you there?
Yeah. Hello, can you hear me?
Yes,
Yes,
yes.
yes, yes, we can.
Yeah. Sorry.
All right.
So, yeah, Asian population again has more risk as compared to the Caucasian population. And pre-existing dry eyes and meibomian gland disease in children who had already had it before HCT, those kids are more have more risk of getting uh, ocular GvHD post the transplant. Higher donor or recipient age is again, increases the risk. And again, one study has found diabetes again to be associated with more risk of ocular GvHD. Next slide, please. So, how do we define, or how do we define ocular GvHD? There are two basic criteria. One is the NIH criteria for defining ocular GvHD, wherein a new onset of dry eye after HCT documented by a Schirmer's test. So Schirmer's test is basically a test wherein we use a tissue with markings on it, and we place it in the lower aspect of the eyelid, and we measure how much of the wetting of the tears is caused in that. So if both the eyes stains less than 5 millimeters at 5 minutes, then we call it as an ocular GvHD. Or if there is a new onset of keratoconjunctivitis sicca by slit lamp examination with the Schirmer's test reading is between 6 to 10. So then if it's either less than 5 in both eyes or 6 to 10 with keratoconjunctivitis sicca, then we put the diagnosis of ocular GvHD. Next slide, please. So grade 1 is again there are only mild symptoms of dryness, and or most of the times the child is asymptomatic. You may see a little bit of reduction in the Schirmer's test values. Grade 2 is again moderate dryness, but here there can be irritation, a little bit of foreign body sensation, pain or redness, but there won't be any impairment of vision in this. And grade 3 is the most severe form of this condition, wherein vision also can be affected, especially by keratoconjunctivitis sicca. Next slide, please. So what is this keratoconjunctivitis sicca? So we've been talking about it all this while. So a triad of dry eyes, dry mouth, and rheumatoid arthritis. Any two of the above three, if present, is called comes under this syndrome. So dry eye is caused by lacrimal gland involvement. Dry mouth is because of involvement of the parotid, and rheumatoid arthritis as because of the other system involvement. So any joint involvement, inflammation because of this condition. So combination of these three, any of those two, if it's present, it comes under keratoconjunctivitis sicca. Next slide, please. The other criteria for defining ocular GvHD is based on the ocular surface disease index. Here, we do the Schirmer's test, which we mentioned earlier, without using an anesthesia, and we so that score is taken. Along with that, we also use the corneal fluorescein staining, which again maps which all areas are dry and which all areas of conjunctiva and cornea are involved. And also we look at the areas of conjunctiva based on various segments. We divide it and look for which all segments are injected or inflamed. And then based on all that, we devise a score. And a score of more than 6 indicates a probable or definite GvHD. Next slide, please. So screening recommendations, who all need to be screened. If any of those kids, as we mentioned, the risk factors, whoever has risk factors need to be screened. Um, and all children in general undergoing before HCT, before the procedure, once it's better, because sometimes the meibomian gland disease or dryness in the eye may not be that apparent. So when we do the test, we can find out which kids are more at risk of developing symptoms post the HCT. And for screening, as I mentioned, because it's only more common in the chronic ones, chronic GvHD. So for screening, usually at 6 months after HCT can be done. And from then on, every year, once checkup if there are no symptoms. If there are symptoms, then probably the frequency of follow-up will be much lesser. I mean, you need to be more frequent in the follow-ups. Next slide, please. So, how do we diagnose this condition? So all the symptoms of an autoinflammatory reaction like irritation, pain, watering, burning, dryness, itching uh, can be seen in the early stages. Later on, once the corneal involvement is also there, it can lead to blurring of vision and photophobia. So foreign body sensation and redness are also common. Because of corneal involvement, there is high risk of developing spherical aberrations which can lead to blurring of vision, and also if there is further rubbing of the eyes can lead to a condition called as keratoconus. uh, because of all this, in general, what happens, the child ends up having an impaired quality of life. So all these three combination is how we come to a diagnosis of an ocular GvHD. Next slide, please. So when we are doing an examination of such kids, first thing, the first sign of ocular GvHD in about 50% of the cases is just a plain blepharitis or meibomian gland dysfunction. So meibomian glands are the glands which are located on the upper and lower eyelid. They run vertically along perpendicular to the lid margin, and any of those meibomian gland, because of inflammation, can the openings of those meibomian glands can be obstructed, which can lead to significant dryness in the eyes, because meibomian gland releases the secretions of the tears, which are responsible to prevent evaporation of those tears. So it forms like a protective coating over the tear film. So if that is absent, that can lead to severe dry eye. So that is usually one of the early signs of ocular GvHD. Also, we can, in a little later stage, keratinization of the lid margin can happen. Further, more severe conditions can lead to conjunctival hyperemia and chemosis, which later on ends up with being fibrosed and scarring of the conjunctiva. Any cicatrization can lead to entropion, dystichiasis, and trichiasis. So trichiasis is basically uh, the lid margin becomes, because of the uh, fibrosis, the eyelashes can become inturned towards the eye, which in turn can rub the cornea and cause scarring as well as vascularization of the cornea. Next slide, please. So again, here we have a grading system for how much is of the conjunctiva is involved uh, in ocular GvHD. So basically, based on whatever areas are involved, whether it's a palpebral conjunctiva or bulbar conjunctiva, which segment, I'll be coming to it little later, showing the segments of involvement, and according to that we give it as the grade, how much area of the total surface area of the lid is involved, how much area of the conjunctiva is involved, how much of it has fibrovascularization. So based on all that, we decide the severity of the ocular GvHD. Next slide, please. So what are the signs that we look for in the cornea? So in cornea, we can have the early changes can be punctate keratopathy, which are all small areas like dot lesions which are present, again, which is noticed when we stain the cornea with fluorescein or rose bengal stain. So when we do that, we will see those dot lesions all across the conjunctiva and the cornea. Then it further increases to become erosion. So for more deeper involvement, which are called the corneal erosions. The much more severe ones are the filamentary keratitis, which is because of much more harder, thicker area involvement of the cornea, which causes severe foreign body sensation in the eyes. Later on, the most severe ones are the corneal ulcers and scarring, which can lead to corneal melting and perforation, which can lead to blindness as well. These are all the very late stages or severe conditions of ocular GvHD corneal involvement. Next slide, please. So this is the picture where you can notice in the first picture, A, which is marked A, you can notice conjunctival hyperemia and corneal staining as well. So the cornea, as you can see, a little portion of that is stained, and the conjunctiva appears much more red than usual. Then the segment B is a little bit more severe, wherein you have the conjunctival scarring and fibrosis. Early stages of conjunctival fibrosis is noticed. Uh, the third picture is when we kind of turn the lid and look for the inner surface of uh, the bulbar conjunctiva, and there we notice again the conjunctiva is much more hyperemic and there is scarring, so which is called the symblepharon. So those are areas of attachments between the palpebral and the bulbar conjunctiva, so there is significant scarring which is noticed. The D picture is what we call as the filamentary keratitis, the more severe involvement of cornea. You can see those small filaments all across the top layer of the cornea, which is, and it's not very easy to remove them as well. And there is specific mode of treatment to take care of those as well. Um, then the picture E is showing a sterile ulcer of the cornea. So the cornea is that particular area where the cornea is stained is deficient in the top layers of cornea, which is why it has taken up the stain much more prominently. And the last picture shows a top small area of perforation, which again full thickness corneal involvement is there, and the eye has kind of opened up, and the aqueous from inside is kind coming out through that area. So these are all the various stages of involvement of ocular GvHD, and probably we should avoid seeing the E and F pictures in our practice as much as possible. Next slide, please. The other signs of involvement of ocular GvHD could be, in a much more severe case, it could be because of episcleritis or scleritis when the sclera becomes inflamed. Also, we do give steroids for most of these kids, and because of the steroids, the side effects of giving steroids, they may end up having secondary cataracts or glaucoma as well. Um, Posterior segment involvement can be in the form of vasculitis or posterior uveitis, so that again needs to be ruled out in such children. Next slide, please. So, any child who comes for an examination of the eye needs a standardized documentation. Uh, so, when at baseline, we document um, before HCT what the condition of the eye is, and in subsequent visits we do the follow-ups. We can check how the progress is happening. Early detection and prevent the worsening of condition. So always mention the vision acuity, eye pressure, and slit lamp findings. Next slide, please. We'll move to the therapy part more in detail. So this is how we assess using the Shermer's test, and also check for the corneal sensitivity in each visit. Next slide. So this is how we grade the eye involvement based on the severity of the staining of the eyes. So how, based on how much stain the cornea and the conjunctiva take up, so we grade the ocular GvHD. Next slide. This is again based on the segments, another grading which where we divide the cornea and the conjunctiva into different segments and do the similar kind of grading. Next slide. So other tests which are done again for the eye involvement, it tells us how severe the involvement of the eye is. Next slide, please. We'll move to the treatment part. Next slide. Yeah. So coming to the treatment of GvHD. Next slide. So the most important aspect of treatment is because the cause of all this is the dryness in the eye, because the tears are not produced from the lacrimal gland, which is from where the tears are mainly originate. That is involved. Intense lubrication using hyaluronic acid eye drops is the mainstay of treatment. So there are various formulations of artificial tears. So based on its viscosity, each eye drop is different in its mechanism of action as well as the duration of its action as well. So based on how severe the condition is, the frequency of the drops also changes according to that. Then, as I mentioned, the meibomian glands are also affected. So, because the meibomian glands are affected, the lipid production of the tears, which protects the eye from getting evaporated, is also affected. So, there are certain lubricant eye drops which are lipid based that again will help in preventing the evaporation of tears. So, those also need to be used in these children. Um, then, as in the more severe conditions like filamentary keratitis, where you have those small erosions over the cornea filament, like there we need to break those filaments, and in such cases, a specific eye drops N-acetylcysteine is mentioned because it breaks the filaments down. So those drops need to be used specifically for that particular condition. Next slide, please. As far as so in a slightly more severe cases or involvement, you may need to start on corticosteroids. Steroid eye drops need to be started. So either in the form of a topical in the eyes alone, which needs to be used as eye drops or eye ointment, or systemically as tablets in the tablet form as well. If steroids need to be spared, or if there are other side effects which are noticed because of steroid usage, you can, or we want to avoid steroids, then we can use the other alternative, which is the cyclosporin eye drops, which has again based a different mechanism of action, but a similar function of reducing the eye surface inflammation. So it also helps in increasing the conjunctiva, or the eye, the tears production on in the eye also increases because of usage of those cyclosporin drops. So when possible, that is an alternative to using steroids. Next slide, please. uh, Sometimes we draw the blood from the patient themselves, and use, so that itself is used to um, uh, generate certain autologous serum eye drops. And we make drops based from the blood itself, so it's based on the serum, because it will have high concentration of growth factors. And also it, because of the medications that the child is on tablet form, that also comes in these drops and has an additive effect in preventing the complications of these conditions. So but there are, not all kids, not all children would be eligible to take up this treatment. Children with severe anemia, or who have active infection or low birth weight, or who have some heart problems as well, they won't be eligible to take up this treatment. Next slide, please. The other option of treating such children, or who are patients who have such severe dry eye, is using punctal plugs. So these are small plug-like things which are present, made up of collagen or silicone, which are which are plugged in areas through which the tears are drained. So it basically retains all the tears in the eye itself. And when those tears are retained, again, the side effects of the dryness in the eye is avoided. So that is one option where we can completely occlude the areas through which the tears are drained. The other option, which is much more costlier, is using scleral lenses. Scleral lenses are lenses which are implanted in the eye for kids who have severe foreign body sensation or eye pain because of the dryness. So when we implant these contact lenses in the eye, that not only improves the vision, but also because of the uniform surface, it reduces the foreign body sensation and eye pain in such children. It's very comfortable for the kid, but the only drawback being that it's kind of expensive on regular usage for such children. Next slide, please. If there are signs of early infection, you can give them eye drops in the form of antibiotics for treatment of meningitis or blepharitis, the lid infection needs to be treated with antibiotics if there is infection. And in very severe cases of ocular GvHD, steroids or cyclosporin can be taken orally in the form of tablets as well. Next slide. Um, when if in very severe cases there are I mean the eye goes on to involve other layers, or as I mentioned, when we saw those areas of severe involvement, then we may also have to consider surgical options. So one of them, as we mentioned, is the punctal plugs. The other option is tarsorrhaphy, wherein we stitch the eyelids together at the end of the eye, so that the eye doesn't remain open for most of the time. So that is called one another surgical intervention or surgical method to protect the cornea. Then we also have something called as an amniotic membrane transplantation. When the cornea is involved and it becomes there are ulcers on the cornea, then we can put a membrane like thing. Amniotic membrane is taken from the placenta, and that again is used for protecting it's as a layer. We put it over the cornea and protect the cornea from developing severe ulcers and preventing perforation of the cornea. Next slide, please. Very, very rarely, if the last resort is the eye transplant or corneal transplant for perforated corneas, the more recent treatment for that is called as an OOKP. Okay, so these are all very rarely performed surgeries, but in for very, very severe cases of corneal involvement. Next slide, please. So here are the various options as we discussed. For the picture shows you the punctal plugs. So there's a small dot which is seen in the eye. So that is where through which the tears are drained. So we put a small plug in that area so that the tears are not draining through that area. The second is the B picture is the of the scleral lens. So those scleral lenses are meant to protect the eyes. Um, and the third picture is the corneal transplant, and the last picture is the OOKP. Okay, next slide, please. So basically, to conclude, management of IGVHD, it has significantly improved over the last few years. And now we have a much better understanding of this condition and newer medications have come up over the last few years. But if left alone, it can lead to severe and blinding complications, which can be prevented with timely intervention. Thank you so much.
Thank you very much, Dr. Shrikant, for that much needed and lucid outline, which was quite in detail. In fact, it was my opportunity to learn a lot of things, a lot of new modalities, a lot of new tests that we can use to pinpoint the disease grades. Thank you for that wonderful outline. It sets the stage for a panel discussion, which will discuss patient-related the issues. And to moderate this session, I welcome Mr. Neeraj Trivedi, a wonderful patient advocate and founder, director of BMT Support Foundation, Pune. I welcome him as a moderator. And for our panel discussion, we are graced by the presence of Dr. Krishna Ratnam Kanan, BMT physician, professor of medical oncology, Cancer Institute, Chennai. Uh, you have already listened to heard to Dr. Shrikant, consultant ophthalmologist. We have with us Mr. Devendra, who is a nurse in the BMT unit department of bone marrow transplant at Actrec Tata Hospital, and we are also fortunate to have a parent of a patient, Ms. Bhavna, who will also share her thoughts and experiences in our panel discussion. Over to you, Neeraj, to begin the panel discussion.
Thank you so much, Dr. Venkatesh, for this kind introduction. into the panel. And Dr. Srikanth, this was, I think, a very concise, detailed presentation that you kind of shared with us. So really, thank you so much.
Mr. Neeraj, you want me to share the slides?
Yes, please.
Please. Yeah.
I think that.
Before we begin, in the interest of time, I request all panelists to be very succinct and to the point when answering the questions. And Neeraj, you should.
Absolutely. Thanks for the heads up, sir. So we already have the introduction, of the panelist given by Dr. So I think straight away, let's jump into the questions. The first question is for Dr. Krishna Ratnam. So are there any, like the group of patients who are prone to develop IGVH? Like, have you seen those groupings?
Okay, thank you. Good afternoon. Thanks for the opportunity. Now of late, I've started concentrating more on this examining the eye, and the more I see, and the more pick up. So the group of patients, to be very precise, are the patients with chronic GvHD, especially patients with extensive chronic GvHD. If you look at them, very clearly, and if you want to look at the eyes specifically, there will be some, or if you ask them, interrogate them, they have some symptoms, like photophobia or early morning stickiness.
Right.
So a group of patients who are at risk will be the patients who are having chronic GvHD. As Srikanth mentioned, it's very, I am yet to see a typical GvHD eye in the acute setup. Maybe it gets overlooked with other problems. But
Right.
definitely a group of patients who are prone for eye GvHD are the ones who have the chronic GvHD.
Okay. And just to add on to that question, is there a time limit after which you see this kind of kicking in? When you say chronic GvHD, is it 1 year, 1.5 years, 2 years?
Yeah, there used to be a time frame, less than 100 days acute and more than 100 days is chronic, but that has been given up now. So you
Okay.
have the overlaps. So you can have acute GvHD type of manifestation beyond 100 days and even chronic GvHD before 100 days. I see quite often patients with lichen planus, you see the mouth, even before that. So the time limit is very arbitrary. So it all depends upon how your immunology plays out. Because the
Right.
chronic GvHD, as you know, it's more an autoimmune phenomenon. So
Right.
definitely, the time limit, may not be a very powerful indicator. So you
Okay.
should go by the clinical pattern of the GvHD.
Okay. Okay. Excellent, sir. Moving on to the next question. And this one is addressed to Dr. Srikanth. Are there any guidelines that we have within the BMT framework for the checkup? I think you just mentioned that 6 months post BMT and then every year annually.
Yes. Yeah. So as I mentioned, even before doing the BMT, if it's better to document the child's eye findings, if are they more at risk if they have blepharitis or meibomian gland dysfunction, that can be documented and they can be seen a little earlier itself post the BMT. And always better to check the eye pressures, visions, and note down all the slit lamp findings along with the Schirmer's test and the staining of the fluorescein. So if we can make a checklist like that, it's easy to follow up those kids.
Absolutely. Excellent, sir. Excellent. Yeah. So moving on to the next question now. And this question is addressed to Mr. Devendra. So in your experience, obviously, you would have seen many patients at track and stuff like that. So what is your eye care advice at the time of discharge for every patient who undergoes transplant? And is there a diet or vitamin that you recommend along with it?
First of all, thank you, sir, for your question. And I would like to thank ISBND team for allowing me to part of the valuable panel discussion. I'll begin with the answer of the first question. So, eye care is an essential part of post-transplant recovery, especially because patients are risk developing eye-related complications like dry eyes or ocular GvHD. And at the time of discharge, patient and caregivers are educated on like monitor for symptoms like dryness, irritation, redness, the blurred vision, or the sensitivity to light. Then like avoid of rubbing the eyes and protect them from the dust, wind, and strong sunlight, and use of sunglasses if they are outdoors. Then limit the screen during the early recovery of the transplant as it is worsen the dryness and eye fatigue. Then report any sudden changes in the eyes to the transplant team to deal with the further complications. And if any prescribed lubricant or eye medicated creams are advised to take to the patient, then without fail or the patient has to apply that medicated eye drops and the cream. and attend all the follow-up for appointments to catch the early complications after the bone marrow transplant. And if we talk about the diet, then patients are advised to avoid raw and undercooked food and instead of eat well-cooked and fresh prepared meals. Eat a balanced and high-protein diet, including fruits, vegetables, and whole grains. Avoid the salty, sugary, or processed foods, including fast foods, because there is a trend of fast food nowadays is very much. And drink from boiled or purified or packed drinking water to be hydrated very well. No need to take vitamins or supplements unless your doctor has prescribed them. That's all from my side for this question, so thank you.
Thank you so much, Devendra. Yeah, moving on to the next question, please. And this question is to this is Mrs. Bhavna. And since you're a parent, obviously, so are there early symptoms that you could catch for your child in terms of dryness or redness of the eyes? And do you see an inability when they do their day-to-day tasks?
Yes, sir. Good afternoon, everyone. My daughter, I would like to share this experience, sir. My daughter was diagnosed with AML at the age of 12 in 2020 and underwent a bone marrow transplant successfully. But after a few years, almost 3 years, later 3 years, she lived a normal life without any medicine. I mean, a few years later, she had her eyesight checked and was prescribed glasses with power. Soon after, she started having pain, dryness, and irritation in her left eye. We consulted many ophthalmologists, but none of the treatments worked. Finally, after several checkups and one specialist reviewed her complete medical history and advised us to consult our BMT doctor. Later, we came to know that this was a treatment and that gave us a new hope.
Right, right. And in terms of her day-to-day schedule, did you see her kind of difficulty in reading or adjusting to a normal schedule, or just was that fine with the drops?
No, she was facing little problem.
Okay.
She was not able to, I mean, her vision was not clear and the dryness was very much, she could not watch screen anymore. She was not able to do her daily day-to-day activities also that time.
Right. Right. Oh, absolutely. Thank you, Mrs. Bhavna. And just for the second half of the question, I'd like to kind of involve Dr. Srikanth here. Are there parallel symptoms you see which go on along with this diagnosis, like a skin GvH in action or something, which is kind of, like a co-ailment that goes along with this GvHD? Have you kind of noticed those kind of symptoms?
Yeah, and most of the time they are already on medications for them with I mean, our Hope team, which is taking care of those kids. So mostly when I see those kids, I deal specifically with the eye part alone.
Sure. Okay. Thank you, sir. And yeah, so back to you, Dr. Krishna, for this question.
Yeah.
So in terms of patients with IGVHD as a part of acute or chronic, is there a difference between the treatments that we would do in an acute and a chronic GvHD?
I mean, as Srikanth also mentioned, and as far as my experience goes, I mean, I'm yet to come across a really significant IGVHD in an acute setup. Because in acute setup, anyway, they are on steroids with an optimal dose. So that sort of gets buried under that. So I have not had a significant issue so far with GvHD in an acute setup. But chronic, yes, 100%. So the treatment will, I mean, if it happens in acute GvHD setup, the treatment will be the same. You have to have the local treatment for the eye, plus the systemic treatment for the acute GvHD, whatever, the skin or liver or the gut, according to the grade. Because, the early stage skin GvHD, you can manage topical steroids. But if it's really a significant gut GvHD, you may have to give systemic steroids. Similarly for liver. So it depends upon the stage of the acute GvHD. And if it's a limited acute, if it's a early stage acute GvHD, low grade, you can just do topical treatment for both. But for chronic GvHD, it's dictated by the severity of the other chronic GvHD, the other sites. And the eye is predominantly by local therapy.
Okay. Okay, sir. Excellent. Next question, please. And this question back to you, Dr. Srikanth. Are there surgical options for IGVH apart from the punctal cautery that you mentioned?
Yeah, apart from punctal cautery, as I mentioned, there is something called as tarsography, wherein we close the outer aspect of the eyelids and stitch them together so that the tears are retained for in the eyes for much longer. Then we also have the amniotic membrane transplant, which is used for covering up the cornea and preventing dryness and perforate corneal ulcers and perforation. And the late stages, we have the corneal transplantation procedures, and the latest one being the OOKP procedure, which is meant to improve the vision also for such patients who have very highly scarred eye. So very severe cases, we use that procedure.
Okay, so excellent. And just one more addition, in case of droopy eye syndrome for elders who've been using like this for significantly, are there options for addressing the droopy eye syndrome? Sir, did we lose you? Dr. Srikanth? Okay, I think we can move on to the next question, please. Yeah, and this question is addressed to Mr. Devendra here. Acute GvH, as you know, it affects the skin, the gut, the liver, and the eyes, and they always need protein. What nursing interventions are required for skin and eye when this acute GvHD kicks in?
Yeah. So actually, for the skin care in our setup, we advise the patient to do check their skin daily for changes, for any rashes or anything else on the skin. Then use mild soap and keep skin moisturized every day. Avoid scratching or wear a soft cotton clothes, so it can be easily suitable for the patient's skin and all things. Then maintain good hygiene to prevent the further infection and to prevent the further complication due to the infections. Then apply a moisturizer or medicated creams as prescribed. So creams like normal moisturizer they can apply, and sometimes if patients some required some steroid medicated creams, so as per the doctor or as per the prescribed prescription, they has to apply that one without fail. And if it is if they feel good also, and further they don't want to use that, then still they have to use as till the doctor tell them to discontinue. Then protect your skin from the direct sunlight by wearing a full sleeve cloth and using an umbrella while going outdoor in the intense sunlight. So that is also important to protect the skin from the sunlight. And then if I talk about the eye care, as I said earlier, watch for the redness, dryness, or any changes in the eye. Then use prescribed eye drops on time. Then don't rub your eyes. Wear a sunglasses outdoors in intense sunlight. If needed, gently clean your eyes with clean water or sterile wipes. Report any sudden pain or changes in the vision to your doctors right away, so to prevent the further complications. Then, and for the nutrition point of view, I already said earlier in my first answer, and like small and soft high proteins meals to be taken by the patient. Drink fluids to stay hydrated. If he or she had a stomach or gut symptoms, switch to bland and easy to digest food or nil by mouth if instructed by the doctor specially. Then they have to keep track of their food and fluid intake and report any issues in their intake. And they have to monitor their weight also if they are prescribed on the specific diet. So there will be a weight changes that can be also helpful diagnose the further complications. And if required, dietitian assistant can be taken to plan the best meal for their conditions. I hope this information was helpful. So
No, this is really helpful, Dr. Devendra. And Dr. Krishna, I just pull you in this question once again. I think one of the things that most patients and even I'm suffering from IGVH is like we feel like washing our eyes very often. Is there a right way to do either washing of the eyes or wearing eye patches like this, which are available? What is the right way to do all these things? Because most patients don't know whether to do it from tap water, drinking water, and I think that causes further complication. So, would you advise on the right way to wash your eyes?
Sorry, this question is directed to Dr. Srikanth or me?
No, you, sir, Dr. Krishna.
Actually, I thought this question will be more appropriate to Dr. Srikanth because
Okay, so let's pass it on. Let's pass it on to Dr. Srikanth then. Dr.
Yeah.
he's
Srikanth, what's the best
authority
way
in
to wash your
ophthalmology.
eyes?
I mean, washing the eyes, I usually tell the patients to use running water or tap water also to splash on their eyes to wash their eyes. Especially cold water can be used. A warm compress actually helps in improving, as I mentioned, they may have meibomian gland disease. So when we do warm compress, blepharitis and meibomian gland disease also is taken care of. So just there are various gel packs or available, which can be either heated or cold. You can keep it in the freezer and that becomes cold also. So you can use those gel packs to keep it over your closed eyelids, and use that to do warm compress for about 5 to 10 minutes in the morning and evening. That would again significantly improve the tear film as well.
Okay. Yeah, that's excellent. I think we can move on. Next question, please. Yeah, and this question is again to, Mrs. Bhavna. How does this affect you when you see your child going through this? And, how do you react to such situations, please?
Uh, GvHD happens, but it also brings emotional stress for us. It is very painful to see our children going through this medicines and eye drops again. Sometimes the child does not want to continue. They feel fed up with the routine of medicines. But we need to motivate them again and again for their benefit. We carry this extra responsibility, which can emotionally be tiring, but still, the hope of recovery, we stay strong and support them. Sir.
Right.
Yeah.
Thank you so much for this, really kind one. And yeah, these are difficult times for parents to kind of see their kids go through this. But thank you so much for your heartfelt sharing. Yeah, we can move on to the next question, please. This is to Dr. Krishna. What is the role of, like a systemic immunotherapy in patients diagnosed with IGVH?
Yeah, I mean, the first line of treatment, my understanding is to give, as Srikanth also mentioned, all the local therapies, including cyclosporin eye drops, steroid, moisturizer, artificial eye drops, etc. Now, the systemic therapy will come into play in two situations. One, the patient may have other areas of chronic GvHD, anyway, which may not be amenable to topical treatment, so he will do systemic therapy. Or if the IGVHD is quite refractory to local therapy as an adjunct. So predominantly, if the eye is the main area of target area, I tend to more use this local therapy and systemic therapy only if it is not responding with some mild dose of steroids, systemic steroids. But if the patient has got, other rip-roaring chronic GvHD elsewhere, like skin or liver, then the systemic therapy will be automatically there as a part of the GvHD treatment. So it will become a sort of a combined treatment in that situation.
Okay, excellent. Yeah, let's move on, please. And this question is Dr. Srikanth. So are there any long-term complications of an IGVH,
Yeah,
either
so
for children and for both adults? I think you can
yes,
comment.
sir. Yes, sir. So all these long-term complications are basically cornea-based. So if it's usually it can lead to scarring and fibrosis of, the scarring of areas of conjunctiva or the top layer of the eye. Uh, then when much more severe cases, when the dryness becomes too much, it can affect the corneal, the clarity, transparency of the cornea, the eye. There can be blood vessels coming onto the cornea, and the neovascularization happens, and it can lead to corneal ulcers. It can start perforations, and all can happen. So those are, and vision can be affected in such cases. So those are the long-term severe complications which can happen in GvHD.
Right. Thank you so much.
Hmm.
Yeah, we can move on to the next question, please. This question is, to Mr. Devendra. I think, this is a practical problem for all of us. Is what is the right way to put an eye drop, and, and how long should we keep it for before we open our eyes and stuff like that? So can you please explain the correct way of applying your eye drops?
Yes, sir. First of all, as you've seen in the image, first we need to wash our hands with soap and water thoroughly before starting a eye drop procedure. Then tilt our head back and look up. Then gently pull down our lower eyelid to make a pocket. Then hold the dropper above the eye. Do not let it touch your eye or the skin. Then squeeze 1 drop or two drop as instructed into the pocket. Then close your eyes gently and press the inner corner of your eye for 1 to 2 minutes, and avoid rubbing your eyes or blinking hard. So and after that, wipes out excess liquid and wash hands again. And if using a more than one eye drop, wait for 5 to 10 minutes or as instructed by the physician or the ophthalmologist before applying the next. And keep the dropper clean and always close the bottle after use. And store the drop as instructed on the label. So to prevent the spoiling of the eye drops, like sometimes we need to keep in the sunlight and all the things, so that can be difficult. So the eye drops will spoil their what we can say, um, shelf life and all the things. So we need to store it properly into the as instructed on the label.
Okay,
So,
excellent. Thank you so much. I think that's the right way. And I think one more question patient often ask us is there a need to keep the eye drops in the refrigerator, or it's not required in a normal dark cool place is enough?
mostly most of the eye drops are room can we can store in the room temperature, but Dr. Shrikant sir is there, so they
Yeah.
will
Yes, most of the drops you
discuss a
can
lot
store
about.
it in room temperature. It's just that cyclosporin eye drops in particular needs to be refrigerated, especially after it's opened. So it comes in unims. So each of those unims have 7 or 8 drops. So it can be used for, I mean, the normal dosage is twice a day. So it can come for, say, a couple of days. So once you open the unim, it needs to be definitely kept in the refrigerator. Before that, you can still keep it in the room temperature.
Yeah.
Yeah, excellent, sir. Thank you so much. We can move on to the next question, please. Nirav, can we move on? Okay, this question is back to you, Dr. Krishna. Can a patient have more tablets and immunosuppression, or is it only better to use a local eye drops in case of chronic GvHD?
Yeah, John, as I said, depends upon its isolated ocular or accompanied by other areas. If it's overshadowed by the other areas, then you definitely use systemic therapy for that, plus the local drops for the eye. But if it's limited to the eye alone, which again we see sometimes, then we limit to local treatment alone. As far as possible, we try to avoid systemic immunosuppression, no, because of the fear of reactivation of opportunistic infections. Unless
Mm.
the GvHD is not amenable to the local therapy. But by and large, I have found ocular GvHD per se is quite amenable to quite intensive local therapy.
Okay, sir. Excellent. Thank you so much. We can move on to the next question. Are there any more questions, Nirav? Yes. Yeah, Dr. Shrikant, photophobia and dry eyes, right? I think two of the major,
Yeah.
really big symptoms that all of us kind of go through. Which treatment gives the best symptomatic relief for this?
Yeah. So lubricants will help in reducing the symptoms, but more importantly, a few changes in day-to-day life in their lifestyle can also help them. So as photophobia is mainly caused because of the corneal irregularity or filaments in those patients. So the specific eye drops which can treat those need to be given, and also sunglasses or staying in cooler, wearing those caps which prevent direct hitting of the sunlight on the eyes. So those can help as well. So apart from that, staying in cooler areas also help them. Not directly looking at the AC, but staying normally in a cooler environment prevents the eyes from getting dried up faster. So those are no, not much of rubbing of the eyes also should be done. So in general, these are the few things which they can take care in their day-to-day life, apart from putting the medications that have been advised.
Right. Thank you so much. Can we move on, Nirav? Next question, please. This question is again to Mr. Devendra. How do you talk to patients who have IGVH and actually provide psychological support for families?
Yes, sir. As we all know, supporting families dealing with the IGVHD or other post-transplant complication is crucial, as it can be emotional and physically challenging. And providing psychological support not only helps them cope better, but also strengthen their ability to care for the patient. So we need to explain clearly what IGVHD and what symptoms to be expect, so they will get an idea about the GvHD. Also, we need to allow the family members to share their concerns and offer a comfort. Then also we need to teach them that simple ways to reduce stress, like deep breath exercising or rest breaks. And we also involves a family care planning, so they feel more in control. Then, as we all know, own health and well-being of a caregiver is also important. So we need to instruct the
Right.
caregiver to take care of themselves as well. So if they are good, then they are going to take care of the patient also. So that is also important thing. And we encourage the patient and families to connect with other families facing the similar challenges, to reduce the stress and anxiety within them. And then sometimes patient and families feel very stressed emotionally, as well as physically also. So we need to guide them to a mental health professional or psychological, after discussion with psychologists, after discussion with the consultant. with the We also know that suggest they we also suggest the join the supportive group, like BMT supportive group or talk counselor. And if required, we arrange for expert doctors or counselor to answer their queries. So whatever the question they can have, that can be identified and clear. And as we all know, financial and other support is also important to deal with the GvHD treatment and post-transplant complications. So we provide information about the social workers, then crowdfunding, and sometimes home care. So we need to provide that information to the patients also. So that's all from my side, sir.
Oh, excellent. Very well said, Mr. Devendra. If there are no more questions, I think it's just about time that we end the session. Are there any more questions?
Last.
Yeah,
No.
last question. Okay.
Yes,
Yeah,
yes,
this
go
is
ahead. Please go ahead.
again question to Mrs. Bhavna. During the therapy for IGVH, what are the challenges that you normally face? Like, have you seen that one medication maybe not working and you had to look for alternatives? Or was there a time before you settled in the medications, or any other challenges that you faced during this time?
The medicines were working, but during GvHD, she
Hmm.
has to face many other challenges. Like after living a normal life for some few years post BMT, she suddenly need
Hmm.
to go back to so many medicines, and her entire routine get disturbed. Like she does not like even been noticed when she has to put in eye drops every hour, and she was not allowed to go swimming. She was also supposed to avoid dusty places, which further restricted her activities. Some of her medicines included steroids, and due to that, she started putting on weight. In addition, she was not able to focus screens using laptop and other this screen caused significant irritation in her eyes. So many things in life were getting disturbed at once. But with the constant support and encouragement, she continues to cope and adjust for the sake of her health. But these are the things she has to face. That.
Yeah, that is difficult, and we really wish her all the best for her future and whatever she wants to do. So yeah, so really thank you so much for that heartfelt sharing. And over to you, Dr. Venkatesh, for the closing remarks.
Thank you, Neerad. I thank all the panelists, particularly our experts, Dr. Krishna Ratnam and Dr. Srikanth. And special thanks to sharing the experiences, Mrs. Baldava. Uh, and thank you, Devendra, for a wonderful input on all aspects of care while uh, going through this journey of GvHD. And now hand over the proceedings to Dr. Silky Jain, my associate, for a vote of thanks.
Thank you, Dr. Venkatesh. So, I would like to thank everybody who has participated in this webinar about a less discussed topic. I would say we often talk about GvHD, but we often forget to talk about the nuances of the rare GvHD manifestations like IGVHD. And so, thank you, Dr. Venkatesh, for leading this discussion, and to Mr. Neerath for being an excellent moderator. And I would like to thank Dr. Shrikant, Dr. Krishnakanan, the physicians who have joined us today and have enlightened us with a lot of knowledge about IGVHD, and to Mr. Devendra for sharing the nursing perspective of it, especially how to instill the eye drops. And special mention about Mrs. Bhavna, who came forward and shared her personal experiences of dealing with this disease. I think it matters a lot for the patients who have dealt with this, because it's not an easy thing. It's a struggle for them. So I think they must have learned a lot. So thank you so much to all the audience as well for your patient listening. And last but not the least, to Revati ma'am, who has been the driving force behind these patient support group webinars. So next month, we'll be back on the 13th of September with another interesting topic, which would be announced soon. Thank you.
Thank you, everyone.
Thank you, and have a good day, everybody.
Yeah, thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you so much.
Thank you.